Hello again. This is Joe Rule with Excel Physical Therapy. I'm a partner at Excel, and we have 33 clinics located in the Delaware Valley. And today, I want to welcome Russ Sarault, the clinic director of our Villanova clinic. Today, we're going to talk about the physical therapies management of the chronic tendon problems that Dr. McShane talked about a week and a half ago. So, Russ, welcome.
Thanks, Joe. How are you?
Good, thanks. Appreciate you taking the time out of your schedule for this. Hey, Russ, tell us a little bit about yourself and the Villanova clinic.
Sure. I've been here myself for 13 plus years now, all with Excel the whole time I've been treating or a therapist here in our Villanova location. The location's probably been here for 15 plus years or so. So that's given me the opportunity to work with Dr. McShane that whole time. I took over as director of this clinic probably 2 years ago at this point. So it's been great. I have the opportunity to work a lot with tendon problems and chronic tendon problems because of Dr. McShane and just because that's what we've done for a long time. So it's allowed me the opportunity to see a lot of them.
Awesome. How many therapists are working there with you?
There are 8 therapists. We have 6 of them working right now. One's on maternity leave. The other's out hanging out with their daughter right now during the pandemic. But when things kind of come back to normal, we'll have 8 of us.
Awesome. That's great. So a week and a half or a week ago or so, Dr. McShane spoke about he went in depth about tendinitis versus tendinosis and, his management of that. So can you tell me a little bit about your overarching philosophy as you deal with the same tendon problems that you see in your physical therapy practice? Sure.
Number one is that we hate the word tendinitis in our office. And because some of the things that Dr. McShane probably talked about in the last one is that denotes kind of an acute inflammatory process. And what we need to educate our patients that this is not an acute thing that can just kind of get better. It's a process and it's a pathology that has to change over time. And we like to help guide that change and facilitate that change. And so our first part of our treatment of that is education and letting the patients understand that and get on board with it. Because the people who understand it the best, understand how to approach it, do the best with it. Because part of our treatment is that some of this is going to be painful and uncomfortable. That's the nature of how it's going to get better. And the better our patients understand that, the easier for them to kind of get on board and go like, okay, if I'm in pain, but I know ultimately I'm going to get there. They do a lot better. And then it's building on, the addition of manual therapy techniques of specific progressive exercise done in a very systematic fashion to help us guide that process of tendon remodeling, rebuilding, strength, kind of however you want to look at it. And that helps us get us there. And then it's a recovery of function. And what does that patient want to do? Are they a tennis player? Are they a gardener? Do they play golf? And then it's the inclusion of things like that and to that framework we've laid with helping rebuild this tendon is how we can kind of ultimately get them to 100% and back to what they're doing.
So that's interesting that the educational component, that tendinitis is used a lot, tendinitis. So I've been in the office and I inadvertently have even said tendinitis myself and been scolded.
Good.
So tendinopathy. So how difficult is it to help move a person from that tendinitis to thinking about in the tendinopathy?
Yeah, and you're trying to get through a lot of preconceived notions of anti-inflammatories work, and I got to rest it, and I got to ice it, and those things that kind of we thought for a long time and were understood for a long time. And it's easy for a patient to go like, I want to take something that takes the pain away and it'll make the problem better. And the reality of it is that it doesn't. It may just mask it or it may actually hinder it long-term. So when you can lay those things out for them and explain to them kind of in a model why this is, they do better with it. I will literally draw on a piece of paper, this is what a bad tendon looks like, what your tendon may look like, this is what a normal one is, and how we get to here from here to there. And when you've had people who've had it chronically, and they come in, they've kind of been through it. So once you kind of developers show them a new model of, hey, this is how we're going to approach it, it is a little easier from the on because they've tried all the other things and now they go, well, this hopefully makes sense, and I can get behind this and get us there. So that's kind of how we start, because if I'm going to have somebody kind of endure some pain and really explain them they got to work hard they've got to understand it.
Yeah, understanding the why can help them to get to this, the end of it. So Dr. McShane also, he talked about the load, that if you do something new and it's not in moderation, the tendon becomes irritated. You get the pain. It's not inflammation, but you get the pain. So especially more in someone my age, in the 50s and 60s, because this degeneration happens in the tendon. So can you describe what you do how do you help the tendon, if it's been damaged, get to a position where it starts to heal or become more natural?
Sure. So the part of the problem with tendons is they adapt very slowly, slower than a lot of structures in the body. So when you do that activity that might have provoked it, there's usually a baseline your tendons like, and that baseline builds slowly over time. So if you do too much, it sets it off. And that, when you look at literature and research, there's still not a great understanding of why these things kind of go bad. What we kind of see is there are nerve fibers that are in these chronic tendon problems that normally aren't there under healthy tendons. And they're what kind of send the pain signals. And part of what it may do is inhibit those nerve fibers, are releasing neurotransmitters and things that may be inhibiting normal tendon healing because of what Dr. McShane mentioned, some of this walling off of these tendon areas where tears may be. So getting your tendon to adapt to the load and remodel over time is the process. And it does that through load. Your tendons and all of your body responds to the load you put on it. Like I said, the tendon just does it more slowly. So we do that through the manual therapy. You want me to start with manual therapy and I can go from there?
Sure. So before you get into the manual therapy, you mentioned load. What does load mean in relation to a tendon?
Oh, so load would be exercise. So there's different forms of it and how you can apply it. Isometric would be, on a basic level, just making the muscle contract and hold it, and not lengthening or shortening it, just holding it in a position. To start to put some strain through it, to try and train your body to get used to handling that stress. Eccentrics or negatives, if you know what those are kind of putting a load through the tendon or putting it under stress while you lengthen it. And concentric would be the opposite, as you shorten a muscle with a load, which would be like a normal bicep curl.
So the negative, so if you're doing you're raising your elbow up, you're bending your elbow, that's the concentric, and the slowly lowering it down is that eccentric component.
Yep, exactly. Okay. So there's some, when you look at literature, there's evidence for eccentric loading of tendons is beneficial. There's been, there's a camp on doing really long load isometrics. Heavy isometrics are helpful to tendon problems. There's other studies that show just heavy concentric, eccentric, slow loading is helpful. So it's helpful to be with a therapist who's kind of knows the stuff, has been through it, because specific tendons tend to adapt different ways. And it's going to depend on where that patient is and what they can handle, what they can do. So it's helpful to have somebody who can kind of help, guide them through. So, looking like you're probably going to do better with this, and this is why, because you have this issue at this portion of a tendon, at this tendon, because different tendons will respond to different loads better as well.
Okay. So is it tendon? So some tendons respond differently to different loads. So can you say that a tendon is a tendon? The process that happens in the elbow is going to be the same thing as in the Achilles. How you treat it might be a little bit different based on that particular area, but the process is going to be the same?
Yeah, the general concept is the same. Often, most tendon problems happen kind of the origin where they attach to the bone, other than the Achilles tendon, which can have both. It can happen at the end where it attaches to the heel and right in the meat of it as well.
Okay. So let's get back to that little area where the tendon is damaged from living. And then you go out and, as Dr. McShane, tennis elbow, pain on the outside of the elbow, happens more with gardening. So now's the perfect time to go out and garden. So I go out and spend the whole weekend weeding, shoveling, mulching, doing all that stuff, and my elbow's screaming. Mm-hmm. So it lasts 2 weeks. It's not getting better. I go in and I go to see my family doctor or Dr. McShane, and he says, well, you need to start therapy. So take me through how you would progress me or someone like me that has this pain in their elbow and wants to get back to playing, gardening with less pain, or playing tennis or golf or anything.
Sure. So, first is the education component. The other is the exam. What do you look like? What level of resistance can you tolerate? Is the movement there? Kind of all things that PTs are going to look at. And then probably, the other part of the treatment we didn't talk about is we placing you in this kind of pain monitoring model. So we know that there's good evidence that patients do well when you kind of work your exercise and load within this model of, you need it to hurt X amount in order for it to know that we're putting a sufficient load on the tendon for it to adapt, but not so much that we're just driving it nuts and overloading it and potentially causing like a very acute inflammatory stress. But if you don't load it, it's not going to adapt either. Because if you don't ask your tendon to do anything, it's not going to get better. And that's often what we see people happen, is that they do something like if they guard and they hurt their elbow and they hold off and do nothing. And then maybe it feels a little better, and then they go do something again and it goes bad again. So there's this process of hurt and do nothing, where the tendon is actually kind of continues to degenerate because there's no load on it. It's very much like a you don't use it, you lose it situation. And the same little quib I'll throw at people is no pain, no gain. So those two things do apply to tendon problems on a very simple level.
Interesting. So, so what is it that you tell a patient? So you want it to be, 0 to 10 is a common pain scale. So if you have 4 to 5 when you're doing an exercise, then that's a good level versus 7, 8, 9, 10.
Yeah. So I'd say, like, when you read some of the literature, 4 to 5 is probably where they put people. Now it's going to depend on the patient. Is it somebody that you just touch their elbow and they say that's a 9? Well, then I've got to scale it to that person's expectation.
Mm-hmm.
But when you can get a sense of what their scale is going to be, that's kind of the range you'll see when that model that tends to work well.
So some of the things you might do if it's my elbow, you might do some manual techniques. What are some of the manual therapies that you would use to help get this area of thickened tendon a little bit more pliable and more promote the healing?
Yeah. So there's a variety of techniques. So transverse friction massage is kind of the old original one that we'll still incorporate. And that's kind of mainly going in and addressing and kind of working across, doing a deep friction massage across that portion of the tendon. There's some of us who are trained in ART, or active release technique, myofascial release techniques, and then Graston too, which is an instrument-assisted way of doing it. Which this device here, so we use a tool to essentially go in and try and release areas that might be sore, or maybe tendon adhesions too. The other portion of that I want to say is, yes, the initial thought of that is that you're going in to break up scar and release adhesions. But what's probably actually happening too is those nerve fibers I mentioned before, we're desensitizing what's in there and getting them to adapt to a stress too. It's very hard to really change and break up scar by using your hands and things, but there's a big neurologic component to this too that takes effect over time and helps these things kind of heal properly and adapt and improve.
So I remember when I was practicing and doing friction massage, that invariably you could maintain the same amount of pressure, but after a minute or two, the sensitivity goes down a little bit, or the pain the patient might be saying is less. So it's more that the desensitizing of those little ingrowth of nerves in the bad tendon area.
Yeah, so that's 100%, because people will say that to you. Like, I'll stay in an area and it will hurt, and then you stay there and they say, well, you must be off it. And I haven't moved, I'm just working, and that system has become desensitized. So that's the other part of it. You can train somebody to start to develop that understanding too. Part of that educational component, they do well with that as well.
So when I come in, you're doing some of the manual things, you're doing friction massage, you might do Graston. Am I going to start exercising, or am I going to do strengthening or stretching exercises doing that for this?
Yeah, 100%. You're going to do that while you're here, and you're going to for sure do it on your own, because the only way that's better is consistency of loading it too. So you can't come to therapy 2 to 3 times a week and do nothing else while you're not here and expect this problem to get better. But that's a big part of the education part of why and what you're going to do. And it's going to depend on where that patient is of what they're going to start with. Are they going to go home and do one exercise 10 times a day, or are they going to do 3 or 4? It's going to depend. And that's based on the therapist's assessment and where that patient is.
Got it. So what about getting back to, is there an absolute prohibition on doing weeding or lawn work? Or do you tell a patient that, okay, you can go out and do something, but if it gets past this certain number in the pain scale, don't do it?
Yeah, so we kind of, and again, it depends on the person. How much do you think you can kind of pull the reins on them? I'd say I kind of give them the same model as with the exercise. It's allowed to hurt up to this. It should abate quickly. So I would usually say within 20 to 30 minutes of you doing activity that might hurt, that pain has to come back down the baseline. And the third part of that is the next day you shouldn't have a 2-point increase in what your normal pain is kind of getting up in the morning. So often people wake in the morning with tennis elbow, say my elbow is stiff and it's really hard for me to get it moving. If you've gone out and gardened and your elbow is significantly more sore the next morning, then you've got to reduce what you're doing the day before.
Interesting.
That's a lot of the guidelines that come with it too.
Yeah. So you want to keep active, but you don't, again, what got you there was overdoing it. And you're really making sure that people aren't overdoing it.
Yeah, you can't overdo it and you can't underdo it, because not moving the tendon does not make it better either.
Right. So Dr. McShane mentioned that he does this needling procedure. Can you talk about what's your experience with that, as far as, is it very similar to someone who hasn't had the rehab for someone who has not had the procedure? And this idea that it's a certain amount of time that would take for the complete recovery from that.
Yeah, the principles are the same as far as how we approach it. When you have somebody who's had the needling procedure, we kind of think of it as like we're taking that tendon back to base layer. You know, he started an inflammatory process, and now we've got to help and guide it and help it remodel from there. And that takes time, but so somebody who's had that's going to start a little slower as far as how aggressive we are with it. But we are going to be, it's relatively aggressive, as in they start exercise the day of the procedure, they're in therapy the day after. But the loads aren't going to be there because they just won't be able to tolerate it or handle it. But the principles are the same. It's regular movement and stretching. It's progressive resistance over time, and intermittent manual therapy with it.
Great. What haven't we touched? Someone with a chronic tendon problem. What do you think is there anything that we haven't hit upon that would be important for them to understand, that these are the things that we want to focus on or pay attention to as you're recovering from that?
I think it's, what haven't we touched? I would say just the regularity of doing your prescribed exercise, and the approach of you have to have a kind of mentality of, I got to push through this. So one of the analogies that I think Dr. McShane loves analogies, one he'll use is, this is like riding a bike up a hill. You've got to keep riding, you've got to keep riding, you've got to keep riding. If you kind of give up at any point and just say, I don't feel like doing this, you're going to fall back down the hill. But if you push through and get to that point, then it's smooth sailing, and people do well. So often we have patients who, they push their way through this. They do well over time. We get them back doing what they want to do, and we don't see them again for these problems. So once they've done a good job of handling it and taking care of it at its onset or early, they do well long term. We've done a good job of not seeing a lot of recurring cases of it when it's managed right.
That's a great analogy. I mean, that's you just keep pedaling up the hill, keep pedaling, doing whatever you can just to keep that momentum going up to that point. Once you get there, that's great. That's awesome. So I think for me, some of the takeaways, the education, that early component, just helping people to really see and understand what's going on. Manual techniques to help the tendon become less sensitive, as well as to help get it malleable and promote healing. Exercises to help promote healing and strength and across the tendon. And good summary.
Yeah.
Awesome.
I'd say,
Well, Russ, thank you very much. Excel Physical Therapy has 33 clinics in the Delaware Valley. Physical therapists are specialists in the treatment of musculoskeletal conditions to alleviate pain and assist our patients in returning to function. We help people return to things they love to do and their individual goals. Function's different for everyone. It could be running the Broad Street run or walking down the driveway to get the paper. So for more information about how the physical therapist at Excel Physical Therapy can help you or your tendon problems or return to function, please call us at 866-883-9235 or visit us at excelphysicaltherapy.com. Thanks again, Russ. Until our next webinar, stay safe and keep moving.
you too, Joe. Thank you.